Hi, so in this video teaching, I'm going to go over electrolytes. So I went over in another training lab. So this is just going into more detail about electrolytes and, what you need to know and understand. And one thing I would encourage you to do is in the cheat sheet, review the electrolytes on there, but use this as use this video to give you more detail from the cheat sheet. Okay? Alright, so let's go right into it. So let's first talk about, I'm going to talk about potassium first. So potassium, first I'm going to discuss the normal range, but then I'm going to talk about low potassium and then high potassium. So you have hypocalcemia, right, which is low potassium. So the normal range for potassium levels is 3.5 to 5.0. So somebody who has hypocalcemia, that means that they have, that means their potassium levels is below 3.5. So here are some reasons why that is, because you do need to be aware of the causes. What the exam will do is it could very well just straightforward ask you what are the causes of hypokalemia, or it could also challenge you to think a little bit more critically, and it will describe a scenario with somebody who has the causes, and then it wants to see if you can identify if it is hypokalemia. So some of the causes are related to diuretics. So obviously they're getting a lot of diuretics that's causing them to lose potassium. You have nausea, vomiting, that causes low potassium levels because once again they're losing their electrolytes because they keep throwing up. And then another one that should be on here actually is diarrhea. Once again, anything that's causing a deficiency because it's leaving their body is going to cause hypokalemia. And then eating disorders, that's also another one. Patients who have bulimia because they keep intentionally throwing up. So because of that reason, they're not getting the adequate nutrition that they need. So they can be a very severe risk for hypokalemia. So here's the thing about hypokalemia. This is why we should care. It can cause dysrhythmias. It can cause dysrhythmias in the heart, which can have very severe consequences for the patient if we don't treat it quickly. So and one of those symptoms, as you can see in this picture over here, it can widen the QRS complex. That's one type of dysrhythmia it can cause. It can change the heart rate. So we do need to address it immediately. One of the signs and the symptoms of somebody who has hypokalemia is that they're going to be dehydrated. All right. So when they have dehydration, they're immediately risk for hypokalemia. So the priority as a nurse is what? One of my priorities as a nurse is going to be to monitor their lab values. To monitor their lab values closely. That's going to be important. So so now we know what it is, like what causes it. What do we do to treat it? So by far the number one way that we treat low potassium levels is to just give them potassium. So we typically will give them IV potassium or potassium by mouth. So it doesn't really matter which route we give. Like we can do it by the mouth if they're able to swallow okay. Like if these patients, because potassium pills are usually pretty large actually, so if they have any problems with swallowing, we wouldn't give them potassium by mouth, right? If they're elderly patients, we probably wouldn't give them potassium by mouth. Or if they're throwing up, we wouldn't give them potassium by mouth. So they would instead get it through their IV line. And the thing about it, when it comes to IV administration of potassium, You can give it via a peripheral line, but it is more preferred. So write this down. It's more preferred to give it via a central line. The reason why is because IV potassium will burn the patient's veins. It will really, like, they will have, they'll begin to complain, oh my gosh, my veins are on fire. You know, it feels like it's burning me. Can you stop it right now? So, in that situation, when that happens, you know, we can tell the doctor so we can slow down the rate, or we will give the IV potassium with IV fluids, with normal saline, as long as, once again, giving them fluids is not contraindicated. So like if they have CHF, we would, you know, be careful about giving that fluids, or kidney problems, we would be careful about giving that fluids. But otherwise though, you know, we're going to run some fluids in the background. It's almost like them drinking water, you know. So we're going to run some fluids with the potassium, not to you know, to help to decrease the pain, but they'll still get the potassium into their veins. So that's the way that we treat low potassium levels. So high potassium. So high potassium means that the potassium level is greater than 5. And this is considered life-threatening. It is a life-threatening condition. Like, you cannot, if as a nurse, if you just don't do anything, you're considered negligent, high or low. Okay, so it's life-threatening. So here are the reasons that would cause somebody to have hyperkalemia. They could have chronic kidney failure. It could be because they have Addison's disease. It could be because they have a high, they take in too much energy drinks, so a high consumption of energy drinks. You know, because a lot of the energy drinks, they do have a lot of, you know, electrolytes in them. That's why people are taking it, to get energy. But drinking too much of it, though, you know, can result in that. Also, it can also be a result of a side effect from medications, particularly hypertensive medications such as ACE inhibitors. So that's, you know, that's one of the things that we have to also remember as a nurse, is that a lot of these medications that we prescribe for the patient to take have side effects, you know, real side effects. So sometimes it's like a catch-22, because it helps one thing, but then it causes another, you know. So the medications, such as ACE inhibitors, and then also another cause, another thing as well, digoxin toxicity. So patients who have too much digoxin in their bloodstream, they tend to also have an increase in potassium levels as well. Okay, so here's the thing: when they have these elevated potassium levels, once again, it can alter the patient's heart rhythm. And typically, here are the symptoms that we can see. They'll have elevated heart rate, tall peaked T waves, widened QRS complexes. These are the more hallmark signs that we'll see. So the elevated heart rate, I mean, we're talking a heart rate as high as 130, 160 and above. So they're tachycardic. And then tall peak waves is very specific to hyperkalemia, and then also the widened QRS complexes. So treatment. So usually the way that we treat it, it's going to vary, because it really honestly depends on the cause. So you have to treat everything based on really like the root problem. So if the cause is because they have chronic kidney failure, so what's happened is that because they have so much chronic kidney failure, because the kidneys are working terribly, and because the kidneys are not working properly, they're retaining all these electrolytes. So we can give them something called K-Xylate, which is also called sodium polystyrene, and this will cause them to have a bowel movement, and then that will cause the potassium levels to go down. Also as well, we also can treat hyperkalemia with calcium gluconate. That's also very common, and that's usually it works very, very fast too. So calcium gluconate, that will also reduce the risk of because here's the thing you have to understand. If patients begin to have widened QRS complexes, what can happen next? Because remember, you have to always think of the next thing that can happen. That's how the nurse thinks. The next complication, the next problem. So if they can have the widened QRS complexes, if we don't treat that will it will become so widened, so to speak, where now they have ventricular fibrillation. So the calcium gluconate is going to help to reduce that happening. So that's another way we treat it. Another reason why somebody would have high potassium levels is because they have DKA. So diabetic ketoacidosis. So because they have the diabetic ketoacidosis from diabetes, so this is going to result in an increase in potassium levels. So because there's an increase in potassium levels, we're going to treat, the great thing about this is that when we treat DKA and we give them insulin, okay, we just administer the insulin in order to reduce the glucose levels. That will cause the insulin and fluids at the same time. That will cause the uptake of glucose to go into the cell, and that will also shift the potassium to go into the cells, so that way the potassium levels in the blood go down. Okay, so that's one of the ways that we treat potassium levels if it's related to DKA, is by just honestly treating the glucose levels. Another way that we treat hyperkalemia is diuretics. So when patients have heart failure, we give them, because they have heart failure. Because remember, we give medications differently based on their diagnosis too. So because they have heart failure, we give them diuretics as well, and the diuretics will cause their potassium levels, their electrolyte levels, to also go down. Another way that we treat hyperkalemia is by giving them magnesium sulfate. So magnesium sulfate, it's known to treat hyperkalemia well. Here's the thing: it may be if the reason why we would do this, is if, for example, the patient is contraindicated for us to give them the other medications, like maybe they have an allergy, or those are some reasons why. Magnesium sulfate often is also treated in patients like maternity patients who have eclampsia, and so because they have the eclampsia, they have the seizures, and they may also have hyperkalemia, so we'll also treat the magnesium sulfate, which will also help for that reason as well. So these are the different types of treatment for hyperkalemia. So you want to have an understanding of the treatment, and then why would we give one over the other, which I just went over now. Okay, the next electrolyte is sodium. So sodium, you have hyponatremia. So the normal levels for sodium is 135 to 145 milliequivalent. So here's the reasons why you would have low sodium levels. The main reason why is because they have, once again, dehydration. That's a very common culprit, when it comes to this. So dehydration, diarrhea, diuretics, so that's a common reason why. SIADH, which I'll go over later, and then liver disease, and also heart failure, and then drug overdose. So this has a lot of reasons. Drug overdose, specifically with amphetamines, and also it can also be because they drink way too much water. I mean, way too much water. So these are the different reasons that causes low sodium levels. So signs and symptoms, right? So what would we expect to see? Well, we will expect to see nausea and vomiting. They can have headache. They can have confusion and fatigue. They will have muscle cramps and seizures. Seizures is what I would say. Seizures is more predominant when like there's certain levels or drops in the sodium level that will cause certain symptoms. So usually when the sodium goes as low as 116, there's a risk for them to have seizures, a high risk. So that's another reason why we have to treat it soon. So usually this is the order. First they'll have the low sodium, maybe it's like at 130 or something, and then they begin to have symptoms of nausea, vomiting, and headache. Then it gets really low. It starts to get really low, like 124, and now they're confused, which is usually more predominant in elderly patients. You know, maybe like 60, 50, and older. Then if we still don't treat it, now they can have the seizures because now it's going too low. Okay, that's the remember everything that you're studying. You have to think about the order of it happening. So treatment. So what are we gonna do? How do we treat it? Well, it's always the treatment's gonna involve or be dependent on the underlying disorder. So if it's liver disease or SIADH or heart failure, we're gonna treat it based on their underlying disorder problem. So usually one method that we would treat it is giving them fluids if it's not because they have a high consumption of water. So they can have low sodium. So let me explain the patho. They can have low sodium because they're so dehydrated, because they're losing so much electrolytes, their sodium levels went down. They can have low sodium because they drink so much fluids, they're diluting the sodium in their bloodstream. So that's why the sodium level is low. See how it's both reasons? So if the reason is not because they're drinking too much water, then we can give them fluids to help, fluids that contain sodium in it, which is going to be sodium chloride, right? So we can give them that in order to increase their sodium levels. Also, we can also give them salt tablets. So there actually is a medication that's salt tabs, like 2 grams or 1 gram of tablet of salt. Literally, they can swallow the salt, or usually they just swallow it. And it's just salt tablets. Okay, so hypernatremia. So hypernatremia is when the sodium level is above 145. Right, so because it's above 145, here's the symptoms that they're going to have. They're going to have excessive thirst. They're going to have poor skin turgor. These patients, one thing that makes it very like a hallmark sign of hypernatremia versus hypo is the dry mouth, the dryness, that dry mouth, the poor skin turgor. They will also have that restlessness and fatigue. They will have nausea, confusion, and they can have muscle twitching. Okay, they can have muscle twitching, but here's the thing that will help not to confuse you. You have to first, if it's select or apply, you would put all the choices. But if it's just like a question relating to like which one, like a multiple choice, then you have to pick the one that's more predominant for hypernatremia, which is going to be like the dry mouth and the poor skin turgor and the thirst. I'm sorry, I should really say that the one that's the most predominant is the thirst. Okay? Alright, so those are the symptoms. So over here, this picture over here, I just use this picture kind of as just like a little way to like ignore this wording, but it's just kind of like a way to help you to visually understand what is happening on the cellular level when patient has elevated sodium levels. So literally, ignore these arrows, but literally imagine that this is the cell, like this container is the cell, and then out here is the blood. So what's happening is that what will really be happening is that all these are the salt. This would be the salt over here. So a lot of them are outside. Okay, a lot of them are outside. Like all this salt right here, they're all outside rather than going in the cell, and that's why it's so elevated. So here are some causes, because remember, whenever we check the the levels, the labs, we're checking their blood, right? That's how we know what their lab values are. So so here are some reasons why somebody would have hypernatremia. Like I mentioned, is because it could be because they're not taking enough water intake. It could be because they are have diabetes insipidus, and it could also be because there's an intake of hypertonic fluids. So meaning that they took in, like for whatever reason we gave them too much hypertonic fluids, and hypertonic fluids are fluids that are high in solute concentration. So pretty much what's happening with the patient is that they took in too much of the hypertonic fluids. Okay, so hypernatremia, the way that we treat it, the main reason or the main way that we're going to treat it is to, well, if it's because of the hypertonic solution, just stop giving that, and the body will begin to correct itself. So we can stop giving them hypertonic solution that's causing it, or give them fluids. That's usually the hyperone reason if it's due to poor intake of fluids. Okay, the next one now is hypocalcemia. Okay, I was trying to move this for you. But hypocalcemia, the one over here, this one, so this is hyper, this is normal, and this is hypo. Okay, hyper, normal, hypo. Okay, so calcemia. So hypocalcemia, the normal range, you should know this number is 8.8 to 10.7 milligrams per deciliter. Now, some reasons why somebody would have low calcium can include kidney failure. It can also be because they have pancreatitis. It can be because they have hypoparathyroidism, because remember like the parathyroid gland that releases calcium, so it's not working well. It can also be because they had a thyroidectomy procedure, and it can also be because they have kidney failure. Those are some strong reasons why somebody would have hypocalcemia. So the symptoms, though, are going to include and these are very, very significant symptoms here. Hyperactive tendon reflexes. So meaning that, you know how you go to the doctor's appointment and they have that hammer and they hit the kneecap to see if you respond or move, especially with children. Like literally you do that to them and they're like their leg like flings. So hyperactive tendon reflexes, tingling. That's also I would say one of the like an ignored sign. Tingling around the mouth, lips, and extremities, which is paresthesias. And this is an early sign, actually. It's one of the earlier signs of hypocalcemia. A tapping of the inferior portion of the cheekbone that produces facial spasms, which is also known as Chevaux's sign. So the facial spasms is a good hallmark sign of that right there. Then the other one is QT. So this is on the EKG rhythm. QT prolongation. QT prolongation, which can lead to torsades de pointes. So over here, so first they will have, so remember order process, right? First they will have the QT prolongation, and then if we don't treat that, like if we don't give them calcium, then their rhythm will continue to prolong, and now they have torsades de pointes, which is that more jagged rhythm. So QT prolongation means that the time between the Q, right, the Q and the T is long. So this one you can tell, see how it's longer? Like this one is normal, like this period right here. This one is this, you know, it's the same, but over here it's longer. So a QT prolongation is a sign of hypocalcemia. So treatment. So what do we do about this, right? How do we treat these patients? Well, it's really easy. We just give them calcium, you know. So pretty much we give them calcium supplements. There is actually, let me just stick with that. We just give them calcium supplements. We also give them vitamin D. We can also give them calcium gluconate IV, you know, depending on how low the calcium level is. But we give that, and then also magnesium sulfate also does help too. So hypercalcemia. So just as there's low, there's also going to be high, right? So hypercalcemia now is when the calcium level is above 10.7 milligrams per deciliter. So here's some causes. This is some reasons why that we would have this problem. So you have an overactive parathyroid gland that releases too much calcium in the bloodstream, right? So that parathyroid gland is just overworking itself. It's releasing so much calcium in the bloodstream. Medications like also lithium. Lithium is another reason why. So somebody who has bipolar disorder is on lithium. So we have to be careful to monitor their lab values too, because it can trigger a release in the parathyroid hormone, which increases the calcium levels. Immobility. So because the patients are not really moving, you know, they're lying down a lot, they're sitting a lot, that's causing a lot of the calcium to literally sit in the bloodstream. So that causes the calcium levels to go up. All right, and then of course, if they take in too much, so these are all causes. If they take in too much calcium, so they, you know, for whatever reason, love foods with calcium a lot. I don't know, they're just taking in too much of it. Also, one thing that's important to know is that there are actually some cancers that can cause increased calcium levels, and breast cancer is one of them. I believe also liver cancer as well. So there are some cancers that can lead to increased calcium level. So here's some signs and symptoms, right? So this can result, they can have kidney stones. That's one of the biggest things right there. So they'll probably begin to complain of flank pain. So they can also, or pain when they go to the bathroom, especially with males. Osteoporosis, nausea and vomiting, constipation, huge sign right there. Constipation, abnormal heart rhythms, like I said again. A lot of these, if you notice, a lot of these electrolytes, if they're not normal, will cause a change in the heart rhythm. Bone ache, so literally their bones ache. They have bone pain, and then also fractures as well. So treatment. So how do we treat elevated calcium levels? So this is going to involve administering calcitonin to regulate the calcium levels. So we're going to give them calcitonin, which helps to regulate the calcium levels. If it's really bad because they have an overactive parathyroid gland, then we're gonna do a parathyroidectomy procedure, which can, of course, can result in a sudden drop in calcium levels too. And then when that happens, then they need to take calcium supplements. And then we also want to give them fluids, because remember, the kidney stones is a really high reason. So because they're having those kidney stones, we're going to give a bunch of fluids to try to wash it out of their bloodstream. So fluid administration as well. All right, magnesium. Okay, so the last one. So magnesium, you have hypomagnesium, right? So low magnesium levels. So the normal range, you need to know this number, 1.5 to 2.5 milliequivalent, right? So here's the thing, the causes can vary. Hypomagnesium has a lot of causes. So you have diarrhea, you have malnutrition, you have burns. And I would say the burns is one area that a lot of people ignore or forget or are not aware of. That burns can cause low magnesium levels. Medications, so once again, diuretics, Also, aminoglycoside antibiotics are also known to cause low magnesium. Alcohol, that's probably the biggest one right there. Patients who have alcohol abuse, who drink a lot of alcohol, they will have low magnesium levels. And that's when we have to, usually when they come to the hospital, patients who are alcoholic, we put them on something called a banana bag, or pretty much it's an infusion of a lot of electrolytes into their bloodstream. So, which includes folic acid, magnesium, potassium, and so forth. So alcohol use is definitely a huge sign. And here's the thing that's so significant. It's a hallmark sign specifically with magnesium. So a lot of these patients who come to the hospital who have alcohol abuse or alcohol use history, a lot of them we give them IV magnesium. A lot of them. We give them IV magnesium. Also renal failure. Renal failure is always going to be a #1 cause of low magnesium levels as well. So renal failure too. Signs and symptoms. So the hallmark sign, okay? Hallmark meaning that this separates magnesium from potassium, calcium, and so forth. So the hallmark sign with magnesium is muscle twitching and cramping. That's one of the biggest things that they'll experience. Palpitations. So they're going to have the palpitations as well. They're going to have muscle weakness as well. So they're going to feel their muscles will feel very weak. They're also going to have the nausea and vomiting as well. They will have the abnormal heart rhythms, specifically torsades de pointes, which, like I said, if it gets to that point, that's really bad. That's very dangerous. Also, they can also have hypotension, which is, now their blood pressure is very low. And cardiac arrest. So as you can see, these ones right here, this one, and this one, those are the more severe signs if we don't treat it right away. So magnesium is serious. Like, we should respond and take it seriously. So here's the treatment for magnesium. Calcium gluconate. So this is just a bottle to show you the image. Typically, honestly, on the floor, you're not going to give it like this. Usually it's going to be like, what will happen is that it's like this, like it will come to us like this to the pharmacy, and then the pharmacy will mix it for us into a piggyback bag. If you are, obviously, LPNs though can't administer this, but as an LPN though, it's still your responsibility. For the LPN nurse, it's still responsibility though for you to make sure they get it. So calcium gluconate will give dialysis. A lot of them, if we just give them dialysis, it treats a lot of the problems, the electrolyte problems. And then also diuretics as well to get it out of their system. Okay, so these are some just like some nursing diagnoses to help you to better, to be familiar with the diagnoses that matches these types of problems with electrolytes. So you have fluid balance, like hypervolemia and hypovolemia. But when you look, especially when you look at the labs, with hypercalcemia, you would see risk for electrolyte imbalance. All of them really. All of them have that's the hallmark thing you'll see with them. Risk for electrolyte imbalance, and then also excess fluid volume or deficient fluid volume, depending on the lab value, or depending on the cause, I should say. And some examples. So once you decide, okay, electrolyte imbalance or excess fluid volume, and then you would have related to. Related to is the cause. So for example, we could say risk for electrolyte imbalance, hypernatremia, related to we'll say related to high consumption of fluids, right? Related to high consumption of fluids. So that's the cause. Another one, increased intake of hypertonic fluids. I said that earlier. So risk for electrolyte imbalance or electrolyte imbalance hypernatremia related to increased intake of hypertonic fluids. You know, so the related to is pretty much the actual cause. And then when you look at, okay, as evidenced by or possibly by, that's the actual symptoms.
And then also another thing too is that if you are trying to really pass your NCLEX exam and you've been struggling, you know, you don't know what you're doing wrong, or maybe it's your first time taking it, but really this is really for people who feel discouraged about the test or just need to get some clarity as far as if they're ready, or they need to know what they need to focus on, then you want to take advantage of our NCLEX assessment program. This program, what I did, this is not like any other program that you're going to find anywhere, right? So because you could take a practice test, you could take a practice questions anywhere, and then the questions are going to tell you generally what you got right and wrong. So this goes beyond this. Not only does it tell you what you got right and wrong, but in the program, I actually help you to understand what you're missing, what your weaknesses are, what your weak areas are, and what you should focus on moving forward, as well as how to create a plan so that way you can be more effective with your approach with the NCLEX. If this sounds like something that you really want to be a part of, or that you really feel like you really need, then go ahead and click right now and take advantage of the program. Go to the link on the screen, bit.ly, right, /assess package 90, or click the link that is mentioned right now on the screen, and you can take advantage of it today, and you get immediate access. And like I said, inside the program, I go over in depth. I talk to you. You'll have an understanding, like as far as in the program, I talk to you in the program through the video trainings and help you to understand what you need to know, what you need to understand, really just kind of guide you. And we've had some people that shared how the program was very eye-opening and just gave them a lot of insight as far as what they're missing and what they need to do differently. So if that sounds like something you want to take advantage of, then make sure you click right now below this video to take advantage of it, either above or below, to take advantage of the program. All right?
So you should be familiar with these diagnoses, because the exam will put questions out there where it wants to see if you're able to identify the appropriate diagnosis based on their medical condition. And if you have any more, if you're not comfortable with diagnosis, then watch the other video, which is called How to Master Nursing Diagnoses. Okay? All right, so that's pretty much it, and I will see you in the next teaching. All right, bye-bye.